Hi, and welcome to another edition of the Trustcast Show. And we're really happy to have with us Dr. Blake Hampton. Welcome to the show, Dr.
Thank
Blake,
you, Zane. I
or
appreciate it.
Dr. Hampton. Well,
You
it's
can, or
okay if
you
I
can
just
call
call
me
you
Blake.
Blake.
Yeah,
Okay.
any of the above.
So, Blake went from valedictorian and neurobiology honors grad at the University of Miami to chief resident at Nassau Medical Center. And now he's not only restoring vision through surgery, but helping reshape how the entire country delivers eye care through AI and telemedicine. Blake, you grew up in South Florida. You were clearly wired for medicine early on. What was the moment you knew that this was the path?
It was definitely the first time I watched one of my mentors in college perform cataract surgery. I didn't know what to expect at all. I had little exposure to it beforehand, and just watching him perform the surgery and being able to see the anatomy so well under the microscope and being able to restore someone's vision in a very highly technical but often successful way. It's just that definitely sealed the deal for me.
So let me ask you some cataract type. I want to
Sure.
dive into the
Yeah.
idea of your AI. I'm personally kind of interested in that and
Sure.
telemedicine, but let me dive into a little bit of the cataract medicine. So
Yeah.
my eye doctor just told me I have a cataract. How do I know if it's actually time for surgery or if I can wait or should I wait?
It's an extremely common question, and a lot of patients who are referred to me for cataract surgery, they're under the impression that they need it. They were told by someone else that they need to have cataract surgery, and the truth is, it's rarely an emergency. Most people can safely wait. And simply put, a cataract is when the natural lens inside of your eye starts to become cloudy. And for most people, it's a gradual process. At first, you may just notice more difficulty, reading road signs or looking at your phone. You may have more glare with oncoming headlights at nighttime, more difficulty in rainy, foggy conditions. But if you're getting by okay with your current glasses, contact lenses, there's no harm in just letting it be. And so it's very much an individual conversation. Yesterday I was in clinic seeing patients. Some patients are very gung ho about it. They want it out of their eye as soon as they can get it, even if it doesn't really seem to be causing much issues. And others probably are waiting a little bit too long. I will say there is a point where the cataract does become so dense and hard that it does start to make the surgery more difficult, and the
Hmm.
risk of complications go up. So I would say, checking in with the eye doctor usually once a year, unless you feel like the vision's getting worse more rapidly, is reasonable just to keep tabs on it, make sure it's not getting to a very advanced state.
So what does the surgery actually feel like? Am I awake or do I feel anything? Is it
Another great
scary?
question. Another great question. So it definitely varies from surgeon to surgeon, surgery center to surgery center. If you go back decades, there was a time where all cataract surgeries required you to be admitted to a hospital and you would stay there for days to maybe a week.
Wow.
The surgery recovery time could be, days, weeks, or longer. And nowadays, it's minimally invasive. It's typically done under conscious sedation. So we give you a little Versed, kind of like Xanax or a benzodiazepine to relax you, ease your nerves, and then numbing medicine on your eye, in your eye. And for most people, that's sufficient. I will say there are those who are more nervous, or maybe they have some other comorbidities that would make it difficult for them to lie still during the procedure, which typically takes around 10 to 15 minutes per eye. And for those, some people do need to be under general anesthesia, but that's certainly rare. That's not the norm.
So what happens in the 10 or 15 minutes? It sounds like 10 or 15 minutes.
I
Sometimes I
know.
have a snack takes longer than that.
I know, and a lot does happen, and certainly there are many videos on YouTube that you could check out. But simply put, The cataract is located inside of the eye, which a lot of people don't know. Some people think it forms on the outside of the eye. It's inside your eye and it's behind the colored part of your eye, the iris. So we have to dilate your iris. We put some dilating drops in to make that black hole in the middle of the colored part of your eye nice and big. And that gives us better access to the cataract. And during the procedure, we basically make a couple of very small incisions. We're talking, a couple of millimeters on the front part of the eye. We go through those, make a small opening into the capsule that the cataract sits in, and then we use an ultrasound device called phacoemulsification to break apart the cataract and remove the pieces. And after it's removed, we replace it with a clear lens implant that goes inside of your eye, and that helps focus light to the back of the eye. So lots of little steps in there. Most of the time, thankfully, it's fairly routine. There are a variety of, anatomical variations that can make that process more difficult. But thankfully, by and large, most people do very well with it.
So if a doctor says, so my doctor says, we have these premium lens and they cost extra.
Yes.
But what am I actually paying for if I get a premium lens?
Zane,
Is
these
it
are
really
great
premium?
questions. These are great questions. So this field has really exploded. I think the first premium lens was offered sometime in the late 2000s, like maybe around 2010, give or take. And since then, it has exploded. The original lens implants, they had a lot of side effects. They have to bend light into multiple focal points so that you
Mhm.
can see at multiple distances. The standard lens implant is what we call a monofocal lens implant. And so typically with that, we can target good vision far away or up close, but you can't have both. So you have to choose. Most people choose, I'd like to see better far away, with the expectation that they'll need something like readers to help them see up close. But for
Right.
people who want to reduce their dependence on glasses, contact lenses, they have a fairly active lifestyle, maybe they do a lot of water activities. These premium lens implants allow you to see at multiple distances without the need for glasses or contact lenses. And again, those earlier versions of the lens implants, they had what we call dysphotopsias. So a lot of issues with light. People would see like starbursts, halos, glare around them. And with the more modern versions that have been released by a number of companies, Alcon, Bosch and Lomb, J&J, uh, the side effect profile has become much more favorable. And by and large, most people tolerate these lens implants very well, and it's really nice to just not have to depend on glasses or contact lenses for the majority of your activities. One thing I should also bring up is this weird word called astigmatism, which a lot of people are confused by, understandably. And to simplify, it basically means the front part of your eye isn't perfectly round. And so that makes the image coming into your eye kind of fuzzy at all distances. And there are lens implants that correct astigmatism, and we call those toric lens implants.
Mhm.
And that's a great way to bring that fuzziness into focus, but just correcting the astigmatism alone won't give you the full range of vision. So you still would have to choose, I want to see clearly far away or up close. So there are a lot of options, and people can get bogged down by them. So it really depends on the individual, your goals, and your anatomy. Some people have other pathology going on in their eye that makes them a poor candidate for some of those premium lens implants, like macular degeneration or glaucoma or diabetes. If those are causing issues in the back part of your eye, then you may not be a good candidate for some of those multifocal or premium lens implants.
So if you got one of the early on lens implants,
Hmm.
because they doing these lens implants for quite a while,
Sure.
could you go back and get an upgrade?
That's another great question. So it's not easy. And I would say there is a window, and it varies from surgeon to surgeon on how long you can wait. to go back and then remove an old lens implant and replace it with a new one. And the term for this is an intraocular lens implant exchange. And I would say most surgeons are comfortable exchanging a lens implant within like 3 to 6 months of having the original lens implant placed in the eye. Some will push it a little further, maybe a year, maybe more than that. But what you have to know is that the lens implant I mentioned earlier, it sits inside of the capsule, and that capsule kind of contracts down like plastic wrap onto the
Mm.
lens implant, which is good. It holds it in position. The drawback of that is if you go to remove it from that capsule, that scar tissue can be pretty sticky and it can be kind of difficult to loosen up those adhesions between the capsule and the lens implant. And so, anyone who's looking into having a lens implant exchange performed has to know that there's a possibility we go in to remove it and it's pretty stuck in there. And if we actually try to remove it, we could cause more harm than good. And we may have to abort the procedure and say, it's too adherent to the capsule. We have to let it be. With the newer lens implants that we currently have available, you still have that risk of those, that contraction, those adhesions forming. But on the horizon, they're already in trials for lens implants that basically are little rings that go inside of the capsule, and then the lens goes inside of that ring. And the idea is you can remove it from that ring fairly easily and replace it with a new lens implant. So that's very exciting, for people who are not sure what they want.
Yeah.
And they're a little afraid to commit to anything because it's a fairly permanent decision, once it's in the eye. So that's something exciting on the horizon.
So, if I was having this done, I worry about complications. Obviously, everybody asks about, well, what the heck can go wrong?
Of course.
And what are how often does that happen? Because
Of
it's
course.
a complication rate to anybody but the person that it happens to,
That's exactly
and then
right.
it's a
It's
catastrophe.
exactly right. And so it's an important question, and I tell all patients across the board, like any surgery, there are risks. So the main ones we worry about are things like infection, bleeding, or in the case of eye surgery, loss or worsening of vision. In the case of cataract surgery, there's the possibility I may not be able to remove all of the cataract or replace it with the new lens implant. And so we may have to come back for additional surgery. Thankfully, these are all relatively rare. Modern day cataract surgery with the use of intracameral antibiotics, where we put a little antibiotic inside of the eye, typically at the end of the case. We're talking about extremely low risk of infection, and we call that endophthalmitis, which can be devastating. But maybe less than 1 in 10,000. Very rare. Thankfully, knock on wood, I haven't had that complication myself. The ones that are more common but still rare are not being able to remove all the cataract or replace the cataract with the new lens implant. And that's going to vary from surgeon to surgeon, their experience, their comfort level, the individual patient's anatomy. They may have, higher risk factors for that. So, but still relatively low. We're talking maybe 1 in 2 or 1 in 300, depending on the surgeon.
So there's a lot of people that are talking about RL. Is that something different? Lens exchange or well, not RL lens, but just coming in to get your lenses placed because you want to stop wearing glasses. There's a lot of people who are advertising. I hear that on the radio as I'm driving around, and of course I don't see as well as I wanted to. And so is that something you commonly see or people are asking about? Hey, I want to see better. So can I just get the lens even though I don't have what typically
Oh, yes, yes.
would
Okay, I know what
precursor
you're talking
this?
about. I think you're talking about RLE, refractive
Yeah.
lens exchange,
Okay, maybe
which
that's it. Yeah.
which is essentially the same thing as cataract surgery, except you're performing it on the natural lens inside the eye before it becomes a cataract. So before it becomes cloudy. And so that is a legitimate procedure for patients with refractive errors, meaning they're nearsighted, farsighted, they have astigmatism, or they have something called presbyopia, where we lose the ability to focus up close. And that typically occurs sometime in our 40s. And that's why, as people hit their 40s, all of a sudden you see everyone, putting on the readers to look at the menu in the restaurant. So, refractive lens exchange, RLE, it goes by other terms, clear lens replacement or clear CLR. So different names for it, but long story short, it's the same thing as cataract surgery, but we're doing it before you form a cataract to address those refractive errors I mentioned. Same idea, trying to reduce your dependence on glasses or contact lenses.
So I'm really curious because I always think of well, one thing I'm curious about is when I also have contacts. I wear those sometimes, but they're such a hassle. I wear them when I'm playing tennis, and that's
Makes
about
sense.
it.
Makes sense.
But I might wear 'em more frequently if I could, put them in and do up close and far away, but everything that I've read and talked about, talked to the ophthalmologist, and they say, "Well, they do have them, but they're not very good." So,
Right, right.
why can they do that with the lens inside your eye and make that work, but they can't do it with a
Another
contact?
great question. These are really, I'm enjoying these. So, in this case, so I was referring earlier to these multifocal lens implants that we place inside of your eye to give you a fuller range of vision, help you see better far away, mid range, computer, and then up close for reading, looking at your phone. The contact lenses that also try to perform this same function also, they rely on similar optical principles. They oftentimes will have little rings in them to cause basically diffractive breaks in the wavelengths, and that gives you those different focal points. But that lens on the eye, the contact lens, it floats on the surface of the eye, and it's also impacted by the tear film. So if you have like a lot of debris in your tear film, you have dry eyes, then the quality of light passing through that multifocal contact lens gets degraded. And so you wind up not enjoying the benefits of that full range of vision because the quality of the vision isn't as good. When the lens implant is placed inside of your eye, it's not moving around. It is stuck in position. And so you don't have to worry about that lens kind of floating on the surface of the cornea, the contact lens, and the image quality kind of coming and going. Now you can still have issues with dry eye and debris in the tear film impacting the lens implant inside the eye, but at least it's not moving and it's closer to what we call the nodal point inside of the eye where all of the light kind of converges and then it starts to spread out again onto the retina. And that nodal point, the closer you get to that, the better the optical quality that you experience. So the contact lens, because it sits on the surface of the eye, it's a little further from that nodal point. So the closer you get, the better.
Okay, so I'm gonna put this on hold just for a minute,
Sure.
because there's somebody else who's trying to get in, and I wanna tell her she's way too early.
No
So just,
problem.
I'll put it on hold and so are you still a resident right now? Are you or have you started your regular practice?
Right. So I graduated from residency in 2022. So I've been in practice about 4 years now, and
Okay.
so I was practicing at a physician-owned small group practice in North Carolina, Alamance Eye Center. I was there for a little over 3 years, and now I'm at Harmon Eye in Virginia. I'm working there part time, like as a locums tenens contractor, and this is a more cataract focused position, which is my main interest. So I started there in January, and so far I'm enjoying it.
So, apparently there's a l there's not enough ophthalmologists, in the country as my research said that there's almost like a shortage.
Yes.
So is that that's true then?
Absolutely. And I can't remember exactly when it was. I think it was fall of last year that they released a report that was basically analyzing physician shortage expectations, projections to 2035. And ophthalmology was projected to be one of the worst shortages by
Hmm.
2035. I think cardiothoracic surgery was slightly worse, but you know, it was something around 70% of the need would be met by the existing workforce or the projected workforce, meaning 30% of those who need an ophthalmologist would not have access to one. And it's a real dilemma, and that's kind of been, you know, why I have, you know, pursued these interests outside of practice, like Frontier Care, which is a company that's focused on bringing ophthalmologists to underserved areas, where maybe there are optometrists in the area who can treat a variety of eye diseases, but they cannot perform the surgeries that an ophthalmologist would be able to provide to their patients who need it. And so it's easier said than done, you know, and it's been
Mhm.
a good learning lesson, you know, pursuing some of these interests, because you realize that unfortunately, a lot of it does boil down to healthcare policy and laws and regulatory requirements that may have good intentions, but they've wound up creating this environment that's, you know, leading to these shortages.
Can you be more specific? I'm really curious about, where our administratively, we're getting in our own way.
Oh, sure. So this is definitely a hornet's nest, and there's a lot of things that we can talk about. Um, you know, I'd say fundamentals, public health is really lacking in the U.S. So basic infrastructure, you know, access to healthy food, exercise, sleep, you know, stress control, education, all these things have to be addressed first, and we're failing in many of those categories. We've gotten worse in many of those categories, and that leads to an unhealthy population, right? So we wind up having a lot of chronic diseases, diabetes, high blood pressure, high cholesterol, and all the subsequent complications of those: heart attacks, stroke, you know, needing you know, amputations for peripheral vascular disease, so on and so forth. And so, you know, it's somewhat of a supply demand issue, right? If you have so many sick people, you're going to need so many more doctors to take care of them.
Mhm.
We haven't been very good about working on things upstream. We've been reactive. We've been, you know, people call it like the medical industrial complex, you know, where, you know, it's not looking to solve these upstream issues. It's more interested in financially, you know, reaping the benefits of treating the diseases much further downstream. But then you wind up with these shortages, and on top of that, you know, not all doctors want to practice in, say, Nebraska or, you know, Wyoming.
Right. That's
And
a real
so
problem.
that's a real problem. You know, how do you get someone who's highly trained, educated to move somewhere where maybe they don't have any family or friend connections, or even if they did have family or friends, they still may not want to live there, right? So that's an issue that we have yet to solve, you know, and I was hoping through Frontier Care, you know, there would be a financial model there that would be on par with, say, what an ophthalmologist can make more locally, so that financially it makes sense for them to travel to provide care in these underserved areas on a periodic, regular basis. But when, you know, when you get down to the brass tacks, the numbers don't make sense a lot of the time. The financial resources in some of these smaller hospitals and more rural areas are not there to compete with what a
Mhm.
physician can make elsewhere. And so for them to take the time away from, say, family to travel and, be in one of these areas, the math just doesn't make sense. It winds up being more charity work, which of course is wonderful. But when you're
Right.
trying to scale something and, meet a very large population health issue, it's going to take more than charity.
Right. That makes sense. Yeah, I know my son's been, we don't want to talk about that on the podcast, but I do know that some of these rural areas will actually even offer financial packages that in certain specialties that are larger than they can get in a more major town because they
Yeah,
can't get it's almost like we're going to buy our doctor in the community. We've decided we're going to
right,
buy this doctor because it's
right.
so hard for them to get somebody into that community.
Right, right. That's very true. You see these large sign-on bonuses, loan forgiveness, relocation costs being, reimbursed, so on and so forth. But at the end of the day, it's oftentimes a place that, maybe they move there with their family and they or the family members are not too happy there after a year, 2 years, whatever it is, and they wind up saying, I can't take this. It doesn't matter how good the money is. There's nothing to do. I'm far from family, friends. The weather's terrible, so on and so forth. And so I think they're they're trying to buy their way out of this problem where it goes beyond just money, and that's
Hmm.
where I really feel like locums and contractor work can be an effective solution. You don't necessarily have to move there and live there all the time. And there's a number of people and companies that are trying to work this out, to provide more continuous contractor coverage. So there aren't these huge gaps in care in areas that are less desirable to live in.
That makes sense. So tell me about your AI project because I mentioned it on the front
Sure.
end. Tell me about what you have going on there.
Yeah, so I've been working with a company called First History for a couple of years now. It's a Canadian-based AI telehealth company, and the premise is simple. It kind of goes back to the shortage issue we were just talking about. Is is that medical intake is a pain. It takes a lot of time and it's resource intensive to do it well. So, you could just imagine when you go to, say, your eye doctor, they may have some forms for you to fill out. You may interact with a medical assistant, like a technician, who asks you questions about your glasses, your contact lenses, how your eyes are doing, what your concerns are, your medical history, social, so on and so forth, medications, reconciling all that. And then, they have to take all of that information and typically enter it into the electronic health record, the EHR. And so, we've all gone through this as patients,
Hmm.
and it's time consuming. We don't enjoy it. And the data then has to be entered correctly and structured appropriately so we can then use it in a meaningful way. And this process is not perfect by any means. For from my perspective, it's very broken. We're making a tech problem a people problem where we're oftentimes throwing people with less experience or training at this issue to take the medical history, perform the intake with variable success and quality reliability. And then we wind up with not so good patient information, histories, why you're here, what you care about. And so that's what drew me to First History. Chat GPT was kind of becoming a thing. And I was interested in creating my own little chatbot that could help perform, some of this medical triage and intake. And then somehow wound up getting connected to the founder and the CEO of First History, and they didn't have someone to build the eye care content for them. So I helped with that, and it was very satisfying. And we were able to deploy it in my previous practice at Alamance Eye Center. And so instead of patients coming in starting from scratch, having to do all this stuff, they were able to complete this intake ahead of time. So, um, they would receive a link by text. They click on the link, they can complete it on their smartphone, tablet, PC, and that intake would then be automatically pulled into our EHR so that we could view it. And so that the technicians who would then go to grab the patients wouldn't be starting from scratch. They would already have their chief complaint, their glasses needs, their contact needs, your past medical, social, surgical, ocular histories,
Mhm.
medications, allergies. And so it just saves you a step. And where AI comes in is in a number of ways. So, a lot of this is actually more automation, and that by itself is an important thing. I feel like AI has kind of like sidelined automation, but a lot of that is automation, structured intake. So it's more deterministic. For this given answer, you get this given question. But then AI is used to generate additional information. So if you are coming in for what sounds like a cataract, it may start educating you about cataract surgery and ask you questions about your knowledge, your personal knowledge. What
Mhm.
happens? Do you know you get a lens implant? Did you know there are different types of lens implants? And can display, custom content to educate you about this before you even walk in the door. So we can have a more informed conversation together as, patient and doctor. And then beyond that, it uses AI to generate some of the code for the application, for the software. And it's also used for natural language processing. So say you fill in something in like a free text box, we'll use natural language processing to determine, okay, this goes on this track of questions. So maybe you
Right.
say you're having blurry vision, and so it's going to recognize that as this is the blurred vision protocol, and it will start asking questions about blurred vision. So, it's what I like about it. It's a little bit more precise use of AI as opposed to just talking to Chat GPT and giving it your symptoms and hoping that it gives you the right response. This is using medical expertise to generate questions that we would normally ask as ophthalmologists, or it's built for a number of specialties, so that you get the data that you want.
So is this out there right now? Is
It
this
is,
available
and
for?
it's being used in, like I said, a number of specialties. I'd say the largest footprint is in Canada, and we've had maybe a couple of million intakes done so far, and a number of partnerships with a variety of companies. So it's exciting.
Yeah.
I'd say again there are regulatory and administrative hurdles. Change management is hard, so getting the data into legacy EHRs requires, talking
An
between the
act of
different,
Congress.
right, an act of Congress, literally. So that's of course frustrating, and that goes back to what we were talking about earlier, where some of these laws seem to be getting in the way of what they're trying to achieve, which is good patient care. So, but it's still interesting and fun to work on.
So I have a bunch more, but I'm running out of time. A bunch more cataract questions. So
I'm
if
happy. Yeah.
someone wanted to, so since you're working, and you don't call it per diem, but you call it something else, but it's similar to per diem. You're
Right,
you're
right.
working, so somebody can't say, "Oh, I want Dr. Hampton. I heard him on this podcast, and I want him to do my surgery." So
Well, I'm
so we get
actually, it is a little bit more structured. So I operate, every Tuesday in Lynchburg, Virginia. That's where the ambulatory surgery center is, and it's a great outpatient surgery center. Patients by and large have a great experience there. And they're used to doing a high volume of eye surgeries. That's all they do there. It's
Right.
strictly for eyes. And so I'm operating there every Tuesday, and then Wednesday I'm seeing patients in the clinic. So post-ops, preoperative consultations. We do some laser procedures in the clinic. And then, as needed, like you said, per diem, I can fill in for a surgeon who's out on vacation, or they have some expected days they need to be out. I can cover for them.
Well, Blake, I usually at the end here I say, well, where can somebody get in touch with you if they want whatever it is that you're offering? But I
Sure.
don't have that. We just had an interesting conversation. Thanks for coming on the show.
Sure thing. Thanks for having me.